When I first started at Hopkins, within a month of arriving, they informed me that we were going to be an HHT Center of Excellence. And as the junior rhinologist, I would be assigned to see all the HHT patients, which is pretty much an oh crap moment. But I will say that taking care of these patients actually has been surprisingly rewarding to me. Many of them have followed me into private practice. It's not as bad as you might think. My goal today is to sort of give you pearls about how to approach these patients, or you just send them to Dr. Davis, which is fine. So Epistaxis is very common in the general population, right? We all see nosebleed patients. I probably, on average, this time of year, see 2 or 3 a day in my clinics. Up to 60% of people during their lifetime will have nosebleeds at some point in their life. But HHT epistaxis is very different. So one of my first pearls to all of you is don't treat an HHT patient with nosebleeds the same as you do everybody else, okay? For HHT patients, 90% of HHT patients present with some type of epistaxis. HHT patients very seldomly die from their epistaxis. And this is one of the things I tell them when they come to my office is I say, you're not going to die from this, but this is what's going to bring you into the doctor. They may have pulmonary AVMs or intracranial AVMs, which can kill them, but they don't care about those. They're worried about their epistaxis. This is what impacts their quality of life. So this is what brings them into the doctor. So real quick, HHT, the Curacao criteria is how we diagnose it. You have a definite diagnosis if 3 or more of the criteria are present. It's epistaxis, and it's spontaneous recurrent epistaxis, the presence of mucosal telangiectasias, the presence of visceral lesions, specifically AVMs in pulmonary, cerebral, hepatic, or spinal, or also GI, and a family history. What I will say to you is for all your nosebleed patients, if you meet a patient that says, I have bilateral recurrent epistaxis that I've had my entire life, the second question you should ask them is, do you have a family history? And then you should start in the back of your mind thinking about HHT because it gets missed. And again, you want to know that they have HHT. It's important. Hey, Lee, can you give me the time? All it says is time's up, and yeah, thanks. Whoa, okay. So this is what an HHT patient looks like endoscopically. And I've had colleagues at Hopkins, rhinologists, who missed this diagnosis. So understand what this looks like. If you see a patient with recurrent epistaxis who has either those punctate small little strawberry blood vessels all throughout their nose, or this is the middle is sort of this diffuse interconnected vasculature, or either that or large EVMs. If you see this in a patient, you should immediately start to think this is not the typical epistaxis patient, and this patient may have HHT. So what is HHT? How does it happen? The normal blood, what you get is post-capillary venule dilations, and then direct communication between the arteries and the veins, okay? So what that means is, in the nose and the mucosa, you get telangiectasias. In the organs, you get AVMs. So there's direct communications between the arteries and veins. Okay, so these are high flow, and their walls tend to be very fragile. So it's a setup for bleeding, right? You have a high flow vascular structure with weak walls. So what causes those nosebleeds? Trauma or dryness, right? They sometimes can tend to bleed more when their noses are dry. So real quick, when you're assessing an HHT patient and you meet them, they are going to be the expert on how to manage their epistaxis. When I first started, I would try to educate my HHT patients about how they should manage their epistaxis. And they would look at me, and then I sort of realized these patients have had nosebleeds their whole lives. They know what's best to manage their daily nosebleeds. So I always ask them, how do you manage them? And I may give them some advice, but really each patient's different. And trust me when I tell you, it's probably not going to be you that knows how to manage their daily nosebleeds. Your goal is to reduce the frequency and severity of these nosebleeds, and you can do that. But don't argue with your patients about how to manage them, because trust me, they've gone through every permutation, and they are the experts on their nosebleeds. It's not like the patient that gets one nosebleed a year or has had one nosebleed that's coming to you that you can give advice to. These guys are experts on their nosebleeds. So What not to do. I used to tell my residents that if an HHT patient comes to the emergency room, don't try, and I know that sometimes they need to be packed. Sometimes they do. But try to do it as atraumatically as possible, because what you're doing, and I use a cheese grater here as sort of a mental image, is when you shove a pack in an HHT patient's nose, they have one blood vessel that's bleeding. When you shove a pack in their nose, you now have 3 or 4 areas that have been traumatized that are bleeding. So frequently I hear from my HHT patients that they went to the ER, their local ER, they had a pack, and their nosebleeds increased exponentially. So what do we do? We do atraumatic packing, and I'll talk about that in the next slide. But what I wanted to mention is, review the literature on embolization and arterial ligation. I see this happen all the time. And actually, the colleague at Hopkins that I had, who was a rhinologist who missed the diagnosis, embolized one of her patients. It does not work. The literature doesn't support it. Anecdotally, I'll tell you, it doesn't support it. I've done it once in my career. I had a patient with HHT who demanded to be embolized, and I actually had her write on the consent, "I understand that Dr. Ray says this is probably unlikely going to work." She called me 3 days later and asked me why her nosebleeds weren't better after the embolization. Literally, she did. It generally doesn't work. If it's life-threatening, I asked Dr. Pecker, how does he do it? He said he's done it a few times in his career. If it's life-threatening, you can maybe consider it. But generally speaking, embolization in these patients isn't going to help with them. It may help acutely. It's not going to help long-term. Hey, Lee. Oh. That's okay. You shorted me on my time a little bit too, but that's okay. I'll just go over. So what do I tell the residents when they see these patients in the ER, or what do? I try to use as atraumatic packing as possible. So I use Surgicel, Flow Seal, gel foam, wrapped in Surgicel, anything that's not going to try to traumatize the other telangiectasias in their nose. Silver nitrate. We all use silver nitrate to cauterize patients in the office. It works great for the non-HHT patients. I would avoid, unless it's a very small telangiectasia, using silver nitrate on these patients, because a lot of times you're just going to make it angry. It's poking the bear or the skunk, as Dr. Pecker would say. So cautery works for these patients. You can use monopolar cautery. Obviously, it's going to cause a lot more damage because the distribution of the charge is going to be more widespread. Bipolar also works. Lasers work great too. So any type of cauterization in the OR works great. And I generally recommend that you take these patients to the operating room, because if you're trying to do it in the office, you can get into a lot of trouble with bleeding. You want them asleep and in a controlled environment. These are a couple of papers that people have produced. Elizabeth Mahoney at BU looked at lasers with the YAG. Bobby Gahary at OHSU looked at the bipolar. That's a picture of Dr. Wong's bipolar. That's what I used as a resident with Dr. Wong. And Nate Sauter compared the laser with coblation, and that's the coblation one, and I'll show you a video. The problem with these studies is it's really hard to say what the efficacy is, because none of these studies, and this is a common theme with all the studies that we do in HHT, we historically have not done randomized placebo-controlled trials. The data is very limited, and we don't tend to use objective outcomes. So most of these studies say, ask the patient, did your nosebleeds get better? The only objective outcomes that these studies look at are side effects, complications, and they look at hemoglobin. Okay, so the studies are very limited in terms of defining efficacy. What I'll say is that for the most part, these studies show that it works and that there's no difference. So you should use in the OR what you're comfortable with, okay? And I'll show you what I'm comfortable with. I like using the coblation wand. It's a great endoscopic instrument. And what it is this is the Smith & Nephew ProSize Easy View coblation wand. It creates a saline field at the end with a charge. So it uses electricity in a saline field. It creates what they call a plasma field. It's called coblation or coablation because it uses lower temperatures, so there's less heat. It cauterizes and it has very limited depth of penetration. So you can do, it's got a suction and it's got a coag right at the end. So it's a great endoscopic instrument because you're only using one hand, and it has limited depth of penetration, so it tends to cause less damage and scarring, and it works very well. Hey, Lee, can I get you to play this video? So this is me doing a coblation of telangiectasias in the OR. So you can see here, you can do two things with a coblation wand. You can coblate, which actually destroys the tissue, and you can cauterize, which just does a very superficial cauterization. I tend to coblate laterally or in thick mucosa and cauterize when I'm on the septum. So this is a left nasal cavity. I'm probably using cauterization there on the thinner mucosa of the septum, because you can still get a septal perforation with this. And then on thicker tissue, like at the inferior turbinate or along the ascending process of the maxilla, which is where I'm going here, I tend to use the coblate. And if they have a large AVM or a larger vessel, I'll use the coblate, which sort of destroys the vessel. So here and now I'm on the inferior, now here's on the septum, so I'm probably using cautery there. And you see it's really nice because it has limited depth of penetration. It just destroys the telangiectasias. So I really like this for HHT. I'm going to talk really quickly about traditional therapies, septodermoplasty. It is effective, but it's of short duration. It usually lasts for about a year. The studies have shown that the patients get better, but it's a morbid procedure, right? You have a donor site because you're taking skin, usually from the thigh, and grafting it into the nose. So you're stripping mucosa in the supraperiosteal plane, and then you're putting a graft down. So these patients all recur, and they have a very stinky, nasty, foul-smelling graft in their nose for several months after the procedure, okay? So for my patients, I typically ask them, was it worth it? And they say no. I've had a few patients that have had a lot of success. Quickly, the Young's procedure, it's very effective, okay? This study showed that looked at about 19 patients, 83% of patients had complete resolution of their nosebleeds. But it's a last-ditch effort, right? You're essentially closing their nostrils. They're no longer gonna be able to breathe through their nose. But if you cut off airflow to the nose, those telangiectasias go away and the nosebleeds stop. So I mentioned that there's a lot of issues with the studies. There's not really good objective ways of determining whether we're doing better with each of these therapies. So when I came to Hopkins, Christian Merlot, who's a pulmonologist, and his fellow, Dr. Hogue, put out a questionnaire on the HHT website. And they asked patients about their frequency, duration, and intensity because they wanted to do a validated scoring system for HHT, which we could use in studies to see how well we were doing. Amazingly, almost 900 people responded to the survey. I'll tell you something, HHT people are very engaged in trying to make their disease better, so they will answer questionnaires. So he had a lot of data, and what they did is they created a normalized score of 1 to 10 that they have as a validated score. It's called the Epistaxis Severity Score. Dr. Pecker is a big fan. He's slammed it multiple times with me, but I told him until someone comes up with a better scoring system, this is what we use. You can go on the HHT website and type in Epistaxis Severity Score, and it will ask you 6 questions. You can ask your patient these 6 questions. You can plug it in, and it'll give you a score for them 1 to 10, 10 being the most severe. So I tend to score all my patients when they come into the office. It asks the question of how intense are your nosebleeds? Is it either gushing or trickling? What's the frequency? What's the duration? Are you anemic, and have you had a recent blood transfusion? Okay, you put in all these scores and you get a score of 1 to 10. So let's talk a little bit about the therapies sort of more recently. Rose geranium oil, I published a paper in Laryngoscope in 2013. This works great. The idea is you're putting a viscous substance in the patient's nose that sort of sticks in their nose and helps to moisturize, because we know that dryness and crusting is going to cause those vessels to break. So we looked at about 20 patients. It wasn't a randomized trial. It was actually just a prospective review a retrospective review of prospectively collected data. But we did see that there was a statistically significant improvement in their Epistaxis Severity Score. And we also looked at less severe and more severe, and both groups improved. We order our rose geranium oil from the Mayo Center. You can call the Mayo Clinic, their pharmacy, and they will ship it to your patient. So Hopkins used to do this for me, but then they stopped. Their pharmacy is not super helpful, but you can get any compounding pharmacy to do it. And I have Greg send my email, so you can email me and I'll send you the recipe if you want to use a local compounding pharmacy. It's essentially scented sesame oil, but it really sits in their nose. And for a lot of my patients, it's helped a lot. So Holly Boyer looked at sclerotherapy, where they essentially inject STS into the lesions. This was a randomized trial, and they showed that there was a statistically significant improvement in epistaxis severity. I would read the paper. There's a technical issue with this. You have to do it correctly. They essentially create a slurry and then inject the slurry into the lesions, but there is a risk of blindness. So there is a low downside to that, and you can read about it in the paper. So one of the key elements of HHT is VEGF, which is an angiogenic factor. So Avastin, I'm sure all of you have heard, has become one of the mainstay treatments for HHT. So there's two ways you can do this, IV or injected. Dr. Pecker looked at, in 2015, reviewed 18 studies. Most of them were case reports. Unfortunately, there wasn't enough uniformity to do a meta-analysis, but they determined that there was efficacy with IV Avastin. The downside of IV Avastin is that it's costly, and that there are side effects, including anaphylaxis, hypertension, bowel perforation, and pulmonary hemorrhage. I'll just say that for IV Avastin, I think about IV Avastin for my patients where I'm worried that they may be bleeding from more than one source. So if they have sort of a little bit of nose bleeding, but I think they may have a GI bleeding or bleeding from somewhere else, and I want them to have a systemic therapy, I think of IV Avastin. If I think the main issue is nosebleeds, I like injected Avastin. And I'll talk about that now. So Dr. Davidson, UCSD, looked at 19 patients where they injected Avastin. Stanford has also done a study. The way that you do this is that you want to inject Avastin. I get 1 cc of 100 milligrams of Avastin, and I use half a cc on each side. So it's 4 subsites on each side. I do a sphenopalatine injection, a high septal injection, an injection along the ascending process of the maxilla, and then along the floor of the nose right anteriorly, where the angular facial artery would come in. So it's 4 injections on each site. It's well described in his paper and in Peter Wong's Stanford paper. And Dr. Davidson showed that there was a significant drop in epistaxis severity score, and it was durable of about a year. I'll just say I've probably done this 30, 40 times on patients. They've gotten tremendous benefit anecdotally. I haven't studied it in my own patients. It typically lasts somewhere between a year and 2 years. So I've done about 10 patients as a revision, okay? After a year, I'll do them again. Okay, there is a paper out of Europe that showed this group in Sweden was doing injections every 3 months at twice the dose that I do, and they had a patient get bilateral osteoarthritis of their knees. Okay, so or osteoradionecrosis of their knees. Okay, so that's a side effect. So I will not inject more frequently than a year, and I'll use only the 100 milligram dose. So other medical therapies, Dr. Halderman did a review in 2018. Thalidomide has been shown to improve epistaxis severity, but it has significant adverse effects, including neuropathy. A lot of my patients come in on tranexamic acid. It does show improved epistaxis severity score. That's an antifibrolytic. I don't use it in my practice, but I've had a lot of patients who come in on tranexamic acid. I don't know, Dave, are you using it in your practice at all?
I don't, but I have our hematologists like to use that.
No. Okay, I'm getting the hook with Davis. So I'm going to wrap up by saying this. Right now, there's no gold standard treatment for HHT-related epistaxis. In my practice, I take them to the OR, I coblate all their telangiectasias, and I do bilateral Avastin injections. And I can talk to you a little bit about the codes that I use. But I use a chemotherapeutic injection code, and I use a destruction of nasal lesion code for each side. Most of the studies looking at our treatment don't use any validated instruments. Dr. Peck would argue that the Epistaxis severity score is not a validated instrument, but it's what we have. And they're not randomized placebo-controlled trials. So really, we're still in the dark about what works and what doesn't. And there's a tremendous need for randomized placebo-controlled trials right now. And the last thing, I often think less is better, okay? So you're not going to cure these patients. They're going to have nosebleeds for the rest of their life. So if you can bring their score from an 8 to a 5, that's a big win, okay? Manage your patient's expectations. You probably hear that theme from me a lot, but you have to tell them you're not going to cure them. You have to tell them you're not going to fix their nosebleeds, because if they have that expectation, you will fail. And be honest with yourself and your patient. If you try something and it doesn't work, try something else. Thanks a lot.
Thank you.